Hey there, everybody, and welcome to today's slightly different time of our weekly CEU presentation. Now, of course, we still have about 10 more minutes before we get started, but y'all know I like to log in early, say hi, see if you have any particular questions. I know we went over a lot of sort of in-depth technical stuff last week. This week will be, for the most part, much lighter, much more practical, in my opinion. So hopefully it'll be a more fun presentation. Okay, that's a bit better. I hope everybody's having a wonderful beginning to their holiday week. Or should I say holiday weeks? At least here in the US, we have New Year's Eve. I think everywhere celebrates New Year's Eve. That was sort of a silly comment. So we are heading into that season where there's a lot, and my birthday just happens to fall in the middle of all of this, so it's an extra busy holiday season for my family. And my daughter's is the first week in January. So yeah, we've got a lot of stuff going on. Hello, Neil. Welcome. Glad to see you, of course. I am going to start adding some shorter videos. And when I say shorter, I don't really know how long they are, based on based on other interests, focusing on anxiety and trauma and other stuff. I know we've kind of been hitting this aging and dementia track really hard. However, the reason I'm doing that is to make sure I have that information available and the videos available for the training track we have on working with people in long-term, post-acute, and elder care. In January, we'll be talking about some of the issues that have less to do with dementia and more to do with other things that you might see in long-term and post-acute care, including diabetes, stroke, and wow, my brain's not working this morning. Diabetes, stroke, and addiction. I actually did create 5 of those shorter PowerPoints today that before class. So I know I engaged in my cognitive stimulation therapy. So I shouldn't be too foggy right now. But hey, Adriana. Hello, Chuck. Do you have particular questions? Next week, we're going to talk about managing agitation and distress in people with, in general, but specifically in people with dementia and who may have other difficulties communicating their needs. Overall, I think this series has been enlightening for a lot of us. Remember that it was just January of 2024 that counselors, licensed professional counselors, mental health counselors, psychotherapists began being able to bill Medicaid and actually work with people who are elderly, work with people who are over the age of 65. So there's a whole new learning curve, and I can guarantee you with pretty good certainty that People who are going through counseling graduate school right now and people who have already gone through counseling graduate school weren't taught any of this stuff because it wasn't a population that we typically would be able to work with or provide services to. So this is a whole new thing and a whole new area, which means we have a lot to learn and a lot to integrate into our training programs. So it seems like there's not a lot of questions about Alzheimer's and dementias and stuff that we've talked about up till now. So I guess my question for you for the last 5 minutes would be, what are you most looking forward to, either over the holiday weeks that are coming up or in the new year? One of the things I'm looking forward to is starting a new job working in one of the local long-term care facilities. So that should be really exciting. I mean, I've met them, I've gone out, I went to the Christmas party, but I haven't been able to start fully billing yet. So it'll be really interesting to find out more about what they need in that particular setting. Most of my work has been done with elders who are aging in place. And so they're still living at home. They have Medicare, they have Medicaid in some cases. They may have Medicare Advantage, but they are living in their own homes. And that's a whole different ballgame than when you're working with somebody who is in an assisted living facility or in memory care. A lot of times people who are in assisted living facilities, memory care, nursing homes, they're not there by choice. They're there by necessity or because somebody forced them to be. Chuck asks, do counselors work with residents in recreational therapy? That's an interesting question. And there are certain things we're going to talk about today with cognitive stimulation that border on recreational therapy. But in general, recreational therapists provide the recreational therapy. If you're providing activities that are designed to stimulate the person cognitively, then yes, therapists can bill for it. And I'm going to go on a little diatribe about that at the beginning, about what it is that counselors can do, because we are not just talk therapists. We can do a whole lot more than just sit in a chair and listen and give you minimal encouragers. So it's important to understand what is covered in your scope of practice. And of course, you don't want to engage in behaviors that are outside of your scope of practice. And you don't want to engage in behaviors and do things even that are in your scope of practice that you haven't been adequately trained on. One of the things I've talked about a lot in other classes is EMDR. You do not need technically to be certified by EMDRIA, the International Association for EMDR Therapists, to provide EMDR services. However, ethically, you need to have training in EMDR before you start practicing using it with clients. So there's a fine line there. Do you need to be certified by that body? No, but do you need to be trained on it? Yes. When I was in community behavioral health and I was asked to work with children, I was never trained on providing child therapy. I was never trained on sand therapy or play therapy or any of those things. So I was very much out of my depth. And when I had to do it, it required me ethically to reach out to one of my colleagues who taught those classes at the university and say, hey, Sandra, I don't have a clue what I'm doing here. Can you help me out? And I got a lot of supervision from her, guidance from her, while I was in the position where I was kind of being forced to provide services to that population. And I love kids. Don't get me wrong. I love kids. But because I wasn't trained on it, and y'all know how big I am on ethics, that I did not have the ability to provide what I consider ethical therapy. Unfortunately, captions will be what they will be during the live. Generally, the captions are processed after the video ends and is re-uploaded for on demand. So I don't know if there's a possibility for you to have captions during the live. Good morning, Mallory. Good to see you. I will be uploading this video as an on-demand in the next couple of days. So it will be available to you with captions. It may just not be today if YouTube's not able to provide the ongoing or real-time closed captioning. Hello. Come on. You want to say hi to everybody? Oh, I got to get started. Okay. Yeah. Okay. Boo Boo says hi. Now, oh, wow. Get back, Boo Boo. Okay, let's go ahead and get started. Thank you, Brian. I appreciate you being here and being supportive of the channel. Oh, goodness. All right, let's go ahead and get started. I'd like to welcome everybody to today's presentation on Alzheimer's and dementias, evidence-based intervention strategies. I think in the YouTube title it actually said groundbreaking strategies, but that's just one of those clickbait words they want you to use. In this presentation, we'll review the scope of practice for mental health clinicians, identify who's involved in the treatment process, review the most common cognitive staging tools and their purpose, and discuss evidence-based interventions for symptoms in each piece of life. Counseling is more than talk therapy, and I want people to recognize that. If you are going in to work in an assisted living facility or a nursing home, you may not be able to effectively engage in what we typically think of as talk therapy, Rogerian therapy, where they're going to do a lot of talking, you're going to do the reflecting. If you're working with people who are experiencing cognitive decline, some of the cognitive tools that we sometimes use may not be very helpful. So what can we do within our scope of practice? So counseling is defined as rendering to individuals, groups, organizations, or the general public. So this includes people who are patients and the general public. Any service involving the application of principles, techniques, methods, or procedures of the counseling profession. We can engage in counseling. We can in testing. We can select, administer, score, and interpret instruments designed to assess aptitudes, achievements, or interests, or to understand and measure or facilitate or diagnose problems or dysfunctions within the context of human growth and development. In order to do testing, you need to be approved at one of 4 different levels. If you've got your master's degree and you're licensed, you're going to be able to administer almost every test that's out there, with the exception of some of the more medical neuropsychological tests. As clinicians, we facilitate human development and adjustment throughout the lifespan by preventing, diagnosing, and treating mental health issues, emotional health issues, and behavioral disorders, and associated issues which interfere with mental health and human growth and development. We're going to work with people, for example, on relationship skills if they don't have supportive relationships. Now, that's not specifically a mental, emotional, or behavioral disorder. When you're working in assisted living facilities, or even with older adults who are aging in place, one of the things that you may do a lot of is working with their loved ones or working with their team to help provide care that is individualized for the individual to reduce their symptoms of distress and agitation. We can conduct assessments and diagnose for the purposes of establishing treatment goals and objectives within our scope of practice. And we already kind of talked about what that scope of practice looks like. We will plan, implement, and evaluate treatment plans using counseling treatment interventions. These interventions may mean the application of cognitive, so thinking tools, affective or emotional tools, behavioral, including behavior modification, behavioral activation, and systemic counseling strategies, which include principles of development, wellness, and pathology that reflect a pluralistic society. We need to recognize differences between groups and individualized treatment. Okay, so you get a better idea of what counselors can do. And again, it's not just sitting in a chair and providing a safe space with minimal encouragers. You may need to use different strategies. And we're going to talk about a lot of those strategies today that are really fascinating. But first, let's focus on who's involved in the care of someone who is in an assisted living facility or who is an elder who is experiencing cognitive decline. The system can identify symptoms, triggers, and interventions. So we need to understand who's part of that system, who can provide us information about what's going on and what might help. Obviously, the patient can provide information. If you're going outside of the patient, especially if you're talking to their family or maybe their roommate, if they're sharing a room or something, it's important that you have that appropriate release of information. I will point that out. If the patient has been declared incompetent and has a legal guardian, then you're going to be communicating with that legal guardian as well. And that's a whole different ethical video that I can do at a different point. Also part of the team are the staff at the assisted living facility, the nursing facility, or the home care providers. Getting information from them. Now, there's a caveat in the HIPAA requirements that say if we are communicating with another person who is bound by HIPAA, and we're doing it in order to coordinate care, we do not necessarily need an explicit release of information to coordinate care. You're not going to give them all your progress notes, but you can talk to the nurse that's the charge nurse at the facility, or you can talk to the caregiver that is coming in to provide skilled nursing services or physical therapy services to the individual in their home. Medical providers, obviously, most people that we're working with in these situations are under the care of a medical provider or more. And you're allowed to communicate with them, and you can even bill for it, but we'll talk about that at the end, in order to coordinate care and make sure that everybody's on the same page. Finally, other residents, if they're living in an assisted living facility, for example, who may be causing or mitigating symptoms. You may have Sally come to you or go to the charge nurse or something and say, you know what, Sam seems really withdrawn and I'm worried about him. We used to talk all the time. And then that person can take that information and pass it on to the clinician, coordinate care. Likewise, if there's somebody in the facility that's doing something that triggers your patient, obviously you're going to work with your patient to help them tolerate the distress, but there may be a situation where you've got to do a intervention of some sort. Obviously, if you're involving people in the ALF that are not part of the person's actual medical treatment team, you're going to need to get appropriate releases of information. I can't go over to Sally when I get into work that day and say, hey, Sally, I hear you told the charge nurse that Jim Bob is not doing so well. You want to tell me about that? I can't do that. But what I can do is talk with Jim Bob. You know, we can take the information in, we just can't respond to it, and talk with Jim Bob and see if he's willing to sign a release. So maybe I can talk to Sally. Our goals when we're working in assisted living and just general are to establish and maintain an alliance with the patient and family, go figure, perform a diagnostic evaluation, and refer the patient for any needed general medical care. When you're working with older adults and people that are in post-acute care and nursing home care, a lot of times there are a variety of underlying medical issues that either are being addressed or may need to be addressed. Urinary tract infections and upper respiratory infections, diabetes, those are three of your biggest. We need to assess and monitor psychiatric status for the presence of non-cognitive psychiatric symptoms and the progression of cognitive symptoms. In the past videos, we've talked about the fact that if a person has cognitive decline, then you may be able to slow that process for them. And it doesn't necessarily mean they've got dementia. If they're diagnosed with dementia, that's a progressive disease. Now, there are a lot of things that we can do to slow the progress. So we're going to be monitoring the progression of those symptoms, and we're going to be noticing, hey, what is it that we do that actually helps this person sort of maintain? We want to educate the patient and their family about future symptoms and the care likely to be required. If they're in an ALF, an assisted living facility, or if they're aging in place, it's still important that we make sure that everybody knows as much as they want to about the diagnosis and about what's potentially going to happen and ways to address it to slow the progression. We want to educate the patient and family about the illness, its treatment, and sources of care and support that are available. For example, if they're aging in place, the area agency on aging in your particular area throughout the United States, wherever you are, they have access to a lot of services like Meals on Wheels, and that's one of the bigger ones, that can help older adults age in place and can help older adults have a more fulfilling and comfortable life while they're aging in place. But we also want to let them know. A lot of people don't know about the differences between assisted living and skilled nursing and memory care. So we want to talk to them about these are going to be your treatment options, and potentially talk with them about what their insurance will cover. And that can get kind of sticky. A lot of times your billing person may be able to provide better information. We want to help patients and their families think about financial and legal issues due to the patient's incapacity. If the person is getting to the point where they may need to be admitted to an assisted living facility or a skilled nursing facility, then definitely financial and legal issues, including power of attorney, become important. We want to monitor safety and intervene when required. If you notice that your patient is falling a lot, or if you notice that your patient is having difficulty remembering to take their medication, those are safety issues that we need to address with the patient as well as potentially the treatment team. We want to help them improve their quality of life. We want to maximize function in the context of existing deficits. For counselors, you wouldn't really think about having people engage in movement-oriented therapy to improve their balance as a mental health thing. But if you don't feel safe on your own 2 feet, if you feel wobbly, then you may not engage with other people. And if you're not engaging with other people, then you're not going to have as much cognitive stimulation. You may feel withdrawn. You're not going to have the benefit potentially of as much oxytocin, which we know is an anti-inflammatory. So there are a lot of reasons why helping a person stay motivated to engage in their occupational therapy and their behavior therapy, their physical therapy is really important. Now, there's a lot of things we're not going to do. I'm not going to say, okay, we're going to do our walking now. If that's something they're working on with their physical therapist, because that's outside of my scope. But I'm going to encourage them to engage in it and engage actively in that. And there are other things that I may encourage them to engage actively in. And we want to help them improve their cognitive skills, mood, and behavior. I'm going to go through a few different tests that you might see, and most of these are going to be done by the assisted living facility or nursing home, skilled nursing facility, if your patient is there. If they are in aging in place, if they're living in their own home, this may be something, these may be tests that you choose to administer. But ultimately, it's important to be able to understand if they say, well, John had the slums yesterday and his score was a 22. You need to know what that means because the nurses aren't going to want to have to explain it to you. So the slums, and I really hate that acronym, but it is what it is. The St. Louis University Mental Status Exam is used to assess cognitive functioning to screen for dementia and mild cognitive impairment. Remember, mild cognitive impairment comes before any sort of dementia. They've got deficits in some areas, but it's not enough to actually qualify for a diagnosis of dementia. So the slums will help assess where that person is and sort of help with staging. The components test orientation to their surroundings, their attention, their memory, and their executive functioning. Some of the tasks include naming animals, digit span, figure recognition, clock drawing, and two-story recall. As it says on here, the scoring is 0 to 30. In general, less than 26 indicates at least mild cognitive impairment. By the time they're less than 20, it's an indication that they need to be moved to memory care. If you've got a client who you start seeing and they're at a 25, then once they start getting down around 22 or 21, it's going to be important to really start having some frank discussions with them about the next steps. The Global Deterioration Scale, or GDS, stages dementia by assessing cognitive and functional declines. 7 stages evaluate memory, orientation, judgment, and activities of daily living. So these 7 stages, I have them listed here. It's from nothing to very severe. People who are in stages 1 through 3 may or may not be in assisted living facilities. People who are in stages 4 and 5 are often in memory care. Once they get to stages 6 and 7, hospice is usually called in because their ability to hold their head up, their ability to feed themselves is diminished or completely gone. And they're having difficulty doing some of the most basic tasks. The Montreal Cognitive Assessment, or the MoCA, screens for mild cognitive impairment and early dementia. This is one you're going to see obviously in people who are aging in place and people who are in assisted living. Every once in a while, you may see it in skilled nursing, especially if the person had a stroke or has a history of multiple TIAs, transient ischemic attacks. You may see them doing the MoCA. Most often, it's the slums that they're going to be doing. Components of the MoCA include assessing attention and concentration, executive functions, memory, language, visuospatial skills, conceptual thinking, calculations, and orientation. A total score of 30 is possible, and scores below 26 suggest potential memory care. So there's not a lot of wiggle room here, but it's screening for early dementia. So a score of 26 may still end up having somebody that is qualified for an assisted living facility and is not quite yet ready for memory care. It's going to be a clinical decision. The MoCA can be administered on a monthly basis to provide valuable numerical data for tracking the progression of the cognitive decline. And the FAST, or the Functional Assessment Staging Tool. And this is one I really like because it's very practical. It evaluates functional abilities and how dementia is impacting daily life over time. Stage 1 is a person who has no impairments. Stage 7 indicates severe Alzheimer's disease. And it focuses on that daily function and independence. Can they take a shower? Can they adjust the water appropriately to take a shower where they're not scalding themselves or too cold? Can they cook food? Can they feed themselves? If you click on the link on the FAST scale in the PDF that's in your classroom, you'll be able to see the questions that you're going to review. You're probably not going to ask them each one of these questions. A lot of it is observation. Is this person able to do this? And, well, anyway, it's one of my more favorites. Stage 7 indicates a need for hospice care. This one's not as sensitive as some of the others, but again, it is a great tool for counselors who are working in assisted living facilities and who are working in home care. Most of the tests used for staging involve a lot of subjectivity and have a risk of low inter-rater or intra-rater reliability. You're not trained on how to implement these, and on any given day, any therapist may say something is severely problematic, and another day they may say it's moderately problematic. Our judgments can be skewed by our emotions, by our frame of mind that day. They're not truly objective, and we need to recognize that. Yes, these tools give us a good foundation to go by, but it's not the be-all, end-all. What we really want to focus on is the person's ability to live their rich and meaningful life. Physically, let's look at what can we do to help them be more comfortable, help them manage their pain or their illnesses. What can we do to help them manage their circadian rhythms? What they think is one of the main causes of sundowning is dysregulated circadian rhythms. So what can we do to help them manage their circadian rhythms in whatever environment they're in? Are they able to effectively eat? And this could be maybe they are having difficulty getting their hand to their mouth. Maybe they're experiencing problems swallowing. Maybe they're having difficulty making their own food, whatever it is. And dentures. If they can't chew their food, then it's going to be hard for them to eat and process the food. We need to actually chew it up before we swallow it. And these are things we're not going to treat. If they're having difficulty swallowing, we're going to refer to a neurologist and maybe an occupational therapist. If they're having difficulty with their dentures, we're going to refer to a dentist. But being aware of things and making the appropriate referrals is part of our job. We want to help them figure out how they can continue to toilet as long as possible. And for a lot of people, that means putting in grab bars so they can get up and down off the commode. Some people need to have a toilet by their bedside. And that's another thing. There are a lot of accommodations that can be implemented for people who are having difficulty with mobility and or having difficulty with memory, so they can continue to live their highest quality of life with as much independence as long as possible. We want to pay attention to their weight. If your person suddenly starts losing weight, we want to figure out why. Are they not hungry? Are they in pain? Are they having belly aches when they eat? Are they not getting enough food? One of the most common complaints, unfortunately, in nursing homes and assisted living facilities is that people will ask for seconds and they will be denied seconds. And that's awful. They have every right to ask for seconds. They have every right to have dietary needs met. If you notice their weight is dropping, bring it up with the treatment team to figure out if there's something else going on. If their weight suddenly starts going up, likewise, we probably want to pay attention. Is it actually weight, or are they starting to retain a lot of water, having a lot of edema, and that could indicate an underlying organ issue that may need to be addressed. Just like toileting, we want to make sure they can bathe independently as long as possible, and they can get up and down from their bed, from their chair, and maybe even from the floor. Now, most older adults are not going to willingly go down to the floor, but should they fall and obviously not break something, making sure that they know what they need to do to rotate onto their knees and get up from that position. Likewise, if they can't do that, or if they're worried they can't do that, making sure they have a medical alert pendant is really important. And a lot of state Medicaid covers the medical alert pendant. So check that out with your particular state. Interpersonally, we want to help them with communication. If they're having difficulty communicating with others because they've slowed cognitively, okay, that's fine. We need to validate that they're smart. They're not, they haven't lost anything. It just takes them a minute longer to get their thoughts together. And we need to help the people around them understand. Just be patient. Don't jump in. Don't finish sentences for them. Be patient with allowing them to speak and communicate. And interaction is really important because it increases oxytocin. Oxytocin is anti-inflammatory. Inflammation is one of the main causes of the progression of a lot of these dementias. So we need to encourage them to do what they can to increase oxytocin. Interaction not only improves oxytocin levels, but it also stimulates cognition. And that too will help slow the progression of dementia. Emotionally, let's help them figure out what makes them happy. Providing validation and reminiscence therapy can be very helpful. Remembering that people with dementia, what makes them happy on Tuesday may not make them happy on Thursday. We need to empower them. Ideally, trying to switch gears instead of telling them what to do. Hey, why don't we go over here and play this game? Asking them, would you like to go over here and watch the birds? Would you like to do this? Asking them questions, empowering them to be able to say yes or no or suggest something else is really important. Cognitively, cognitive stimulation therapy, we are going to talk about in a few minutes, and that is a huge part of working with people with dementias. Joining is another issue or another thing that we need to consider. Just like when you're working with somebody with schizophrenia that is in an active psychotic episode, trying to argue with them that their perceptions are inaccurate, you're not going to get anywhere. If you are trying to work with somebody who has dementia, for example, who still believes they need to go to work every day, we need to sort of join them in that instead of saying, no, you don't need to work anymore. Don't you remember you retired 20 years ago? I see that getting to work is really important to you. Maybe tell them you don't have to work today though. So would you like to do something else? Other strategies include redirecting them, giving them something that is purposeful to do in their home, if they're in home or at the ALF, so they feel like they're working, for example. They're sort of working from home. And that's why I say joining with modifications. You're not going to just jump in there and go, yeah, you're right, you've got to go to work, because then the person's going to go, okay, well, take me. We want to validate and acknowledge their belief and then try to help them find a way to manage that given their current circumstances. And environmentally, we need to pay attention to sensory sensitivities. Too much light, too little light. Too much sound, too little sound. Too much activity, too little activity. Manage their circadian rhythms. Of the nursing care facilities and assisted living facilities I've been in, this could make the biggest difference in a lot of cases. Remember, circadian rhythms are set by temperature, light levels, and activity levels. And in a lot of these facilities, people sit in dim or dark areas all day long. The temperature remains about the same, and they don't do much. They sit there and watch TV or just sit in their bed. First, environmentally, making sure it is bright during the day and dark at night. Not having all those doors open so the hall lights are beaming in there. Making sure that the person feels safe in their environment. Encouraging the person to the amount they can to get up and get dressed in the morning. That's a huge trigger in the brain for, hey, a new day's starting. I'm getting up, I'm getting dressed. Not everybody showers in the morning. I'm getting up, I'm getting dressed, I'm going to breakfast. In a lot of the assisted living facilities, it's encouraged strongly to go to the dining room for your meals. Why is this? Not because they want it to be easier for them, although it does help. It's because that helps set those circadian rhythms and will reduce one of the influences on agitation and sundowning. And we need to provide accommodations. If people need a walker, if people need apparently canes are not allowed anymore in most nursing facilities. So people are either going to have walkers or wheelchairs. Making sure they have grab bars where they need them. Making sure they can access their call button if they need to access their call button. All of those things are important. Making sure when they pull their call button that they get a response in a reasonable amount of time. If they're sitting on the commode and they can't get up and they pull their call button and they're sitting there for 45 minutes, that's not good. That's not okay. We'll talk about ombudsman in a little while. So let's talk about some of these interventions. I've given you some ideas about things we're going to focus on, but what do we actually do? Reminiscence therapy is a cognitive and affective intervention. It uses sensory prompts, including photos, music, objects, or scents. It can even, when we think of sensory, visual, auditory, olfactory, smell, even touch can be reminiscent for some people. So sometimes if they're living at home and you go out to the swing outside where they used to sit with their significant other and drink their coffee in the evening or something, that can be a sensory prompt or a sensory trigger for them. You can go out there and sit out there with them and talk about what that was like. Ask open-ended questions and encourage elaboration on past experiences and emotions. Tell me what it was like for you when your husband was gone to the war. Tell me what it was like for you when this happened or what have you. It's important to focus on what they call the reminiscence bump. And this is memories that they have from ages about 15 to 30. So that's your young adulthood and your late adolescence. I'm not sure why 15 to 30 is sort of the magic sauce, but they find that most people with dementia, this is one of the last places that they actually lose their memories. So taking them back to that time. And for me, I'm big into music. And I was trying to think the other day about some music interventions to use. And I was having to take my patient's age and then figure out, okay, what era of music were we in when this person was in their 20s? And turns out it was 1950. But thinking about that, so you know what kind of prompts. You can do research. If you're working in an ALF, a lot of your clients are going to be around the same age, and you can do your research as to what was going on when all of these people, or most of them, were 15 to 30 years old. And that will give you more to talk with them about, to help them reminisce about. And we don't want to reminisce just on, the scary things or whatever. Reminiscing on what was it like when your loved one came back from fighting in the war. Oh my gosh, how awesome was that? You can create memory books or treasure chests. Not everybody has the manual dexterity to create scrapbooks and memory books. Now, you can do it for them. If they hand you pictures or give you things, you may be able to help them put it in the book. Ideally, you're talking about it as you're doing it, because obviously counseling is not arts and crafts. So by virtue of the activity that you're doing, you're stimulating that reminiscence, you're stimulating that cognition, and you're creating sort of a new memory. If you don't want to do that, some people prefer treasure chests, and it's just basically a big box, and you can decorate the box or they can decorate the box if they want to, where they store their pictures, their mementos, maybe little knickknacks and pieces of jewelry that remind them of their past. And group discussions can also be used where people share memories and experiences in a structured setting. You may start out by saying, how many people here remember when their spouses came back from World War II or the Vietnam War? And they'll raise their hand if that applies to them. And then you can start talking about that. I know I keep going back to the war because that's one of those, pivotal points. But you can think about other things that were going on, ideally happy things. Who remembers when JFK was elected? Who remembers, and what did you think about that? Any of this thinking and pulling those memories out, activating those cognitive pathways is really important. Reminiscence therapy helps people go back to a time when they felt safe and empowered, and this helps them turn their attention to times that triggered positive neurotransmitters. So if I'm thinking about when my loved one came home from World War II and how happy I was to see him and how wonderful it was, all of a sudden I'm going to have this flood of dopamine and serotonin and oxytocin and all this other stuff. That's good. That's positive. They are having that reaction. And it also activates those neural circuits. Reminiscence therapy, if you help them focus on positive memories, can help them deal with their sympathetic dominance. That is, the sympathetic nervous system or the stress response system in older adults tends to be hyperactive, and the relaxation mechanism tends to be underactive. If we can help them strengthen that relaxation mechanism, help them activate that vagus nerve and all of the happy chemicals, so to speak, you can help, to a certain extent, rebalance so that sympathetic nervous system isn't as dominant. It can help reduce agitation because it helps them feel safe. They're thinking back and they're feeling like they're back in that time when they were safe. It can help reduce depression. If they're focusing in the moment and they kind of realize that they're not thinking too clearly and they're frustrated that they can't think as quickly, they can start feeling depressed and anxious and all those things. If they're thinking about times in their past when they were safe, when they were empowered, when they were happy, then it can help temporarily alleviate that depression. And we can maybe help them focus on how they can bring some of that into the present. What was it that helped you feel happy and safe and empowered back then that we might be able to do a little bit of now? And confusion. Reminiscence therapy basically says, okay, you're confused in the moment. Let's take you back to a time when you weren't confused. Because when we get confused, we get stressed. When we get stressed, that sympathetic nervous system kicks off and we become more stressed and more confused. You don't think clearly when you're in the fight or flight response. So by turning their attention to the past with reminiscence therapy, we are essentially helping them develop a distress tolerance skill so they can think about a time when they were happier, when they were less confused, and downregulate. When they come back into the present, when they start talking about what's going on now, then they're not in that adrenaline haze. Validation therapy, pretty much what it sounds like. It's an emotional intervention that involves empathetic listening, reflecting, and acknowledging. What you feel, what you think, what you are experiencing is valid for you. I may not be feeling, thinking, or experiencing the same thing, but it is valid for you. And that's important to help people feel like they're heard and they're understood. We can help them articulate non-verbalized emotions, asking follow-up questions to confirm feelings or thoughts. It seems like you're feeling pretty angry today, Ms. Smith. Can you tell me a little bit about what's going on? They may not have said, I'm angry, but you can plainly see that they are agitated, they're distressed. So by articulating those non-verbalized emotions, you're opening up that conversation and the ability for them to try to get those needs met. We're normalizing experiences using phrases like, it makes sense to me that you're exhausted considering your family was here all day yesterday and that was a lot of activity. Or it makes sense to me that you're having difficulty thinking as clearly right now because you had a really big day today and your brain is exhausted. And with validation therapy, we can create a supportive environment for establishing a safe space for the person to express themselves freely. I'm going to validate what makes you feel safe. If you feel safe when the lights are dim and I don't know, whatever situation, whatever characteristics in the environment help you feel safe, then I am going to validate that. Many older adults feel forgotten, powerless, hopeless, and unheard. Validation therapy helps them know you hear them and recognize that in the moment their perceptions are true for them and can serve as a launch point for problem solving. A lot of people with early stage dementia, they have good days and they have bad days, and they are somewhat aware of their forgetting. And it can be exasperating and terrifying. And acknowledging that, talking about it, can serve as a launch point for problem solving. Validation downregulates the stress response, triggers positive neurotransmitters, and activates those neural circuits. The same endpoint that you arrive at with reminiscence therapy. With validation therapy, you're saying, in the moment, I hear you. I respect what you're feeling and thinking and needing, etc. So they're not feeling like they've got to argue. They're not feeling like you're taking their power. They're actually recognizing that, hey, you hear me, and maybe you're going to be able to help me. Scenarios that may come up that can be helpful with validation therapy. The person may think, my kids never come by or call. I was just dumped here. Validation therapy meets the patient where they're at and works to identify solutions. So you may say, it sounds like you're feeling very lonely. I'm wondering why your kids haven't visited in a while. Maybe they live 5 states away. We don't know. But we're opening that up instead of saying, well, you know that they just can't travel this far. We're going to start talking about it. Or you may say something like, even though they were here last Wednesday, I know it can feel like forever because you miss them so much. You're validating it. Even though they're using those extreme words, they never come by and they just dumped me. We're not contradicting that. We're validating how they feel in the moment and then helping them explore those thoughts and feelings. The person says, I have to go to work. My boss is going to be angry if I'm late. They've been retired for 20 years. You may tell them, you know what? The office is closed today. Or if necessary, you may say, I'll call your boss and let him know. If appropriate, and that's if the person's able to understand what you're saying and it's not going to make them feel disempowered and trigger agitation, which is why I say if appropriate, you may remind them that they're retired and they don't have to go to work anymore. It's a case-by-case basis. The client may just start saying, no, 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 no. Okay, well, we don't know what that's about. What we say, validate, I see you're feeling very angry or scared right now. What can I do to help you feel more comfortable? I'm not going to say, I see you're feeling scared, but you're safe. Well, they're not feeling safe. So what can I do to help you feel safe? Or you can say, it's maddening when this happens. You just can't get your fingers to grasp those little buttons. That's a big issue for a lot of older adults, having that dexterity. And they may get really frustrated when they're trying to dress themselves. Appropriate empathy can be helpful too. For example, yeah, I hear you. My hands hurt. When my hands hurt, I wish all my clothes had zippers. I have arthritis in my hands, and I can tell you there are some days that I can't make that pinching motion that's required for little tiny buttons. It can be helpful to change the setting if somebody's feeling agitated. Would you like to go sit out on the patio and talk about this? Avoid saying calm down if possible, as that invalidates their distress. Instead, recognize their distress and let them know you're there to help. I see you're feeling really angry right now. What is it that I can do to help you out? Cognitive stimulation therapy can be part of a therapy session or billed as a standalone service. Word games and puzzles that challenge language, memory, and problem-solving skills can stimulate cognition. And in Medicare, it's billed in 15-minute increments. So if you're going to bill for it independently, it's going to be something short. If you are a caregiver, if you are somebody who's a recreation director at an assisted living facility, a lot of these are great activities for adults to engage in anyway. Word finds can be really helpful. Easy crosswords that are based on common words, like what is the thing you open to go into a room? The door. And there's a website that's puzzle.org, and it's PUZZEL.org. It's really affordable. I'm not an affiliate or anything. It's something I use for making my worksheets and things for Bible studies. But it is a great website, and there are so many different types. You can do word finds, you can do crosswords, you can do sliding picture puzzles. He has like 30 different types of puzzles that you can create. You can play card games, including solitaire, rummy, or Uno, Yahtzee, Jenga. Obviously, this is for your people who have some manual dexterity and aren't struggling with, tremors. Scavenger hunts. This can be a great team effort in a assisted living facility, pairing people up and having different things around the facility that they need to find. That encourages them to move around, and there's a prize to whoever finds them all first. Checkers, backgammon, and again, games they played between the ages of 15 and 30. What kind of games did you play when you were a young adult? And jokingly, I have here, except beer pong, because there were a lot of people in their 20s who like to play that game, but that's not one we're playing. You can encourage them to discuss current or historical events and engage in creative activities like arts and crafts to promote cognitive engagement. If you're going to have them using their fine motor skills a lot, build up to it. You don't want them to experience pain as a result of engaging in the activity. If they're coloring for 2 hours and then the next day their carpal tunnel's acting up, that's not good. So we want to build it up. 10, 15 minutes at first, see how they do. Coloring is possible. You can use crayons, you can use markers, there are some charcoal pencils that are really soft that people can use if they have difficulty with applying enough pressure. Painting, you can use paint brushes, you can use dabbing, which is, just like dabbing a potato or dabbing some sort of object into paint. And that kind of goes along with stamping. Finger painting, if they want to just kind of get in there and do that. Or even stenciling. The nice thing about stencils is you tape it to the paper and then it's big strokes. And they actually have ergonomic paintbrushes for those bigger paintbrushes, not for the little art paintbrushes, but for the bigger like house paint brushes. And you can do stenciling that way if somebody wants to engage in it. Stamping. You can get those little rubber stamps that we used to use for picture books and scrapbooks, and encourage people to use those and make designs. Clay modeling. Using their hands to model the clay can improve hand strength, can give them something to think about. Gardening or planting, baking, and crocheting either with hooks or with looms, depending on the amount of their manual dexterity. You can also encourage them to use music, to sing, play an instrument like the piano, the tambourine, or even the drum. Again, I'm trying to think about people who may have difficulty with their hands or may have tremors and they're not able to do some of the things, but there are other things that they can do. Psychoeducation and health literacy are also strategies we can use. We create an understanding of the issue and problem-solving options to help them move toward their rich and meaningful life. This is one of those straight-up cognitive behavioral strategies. Encourage them to create a vision board for their rich and meaningful life, and you can refer back to that and say, okay, tell me about this person over here that's important in your rich and meaningful life, and tell me who they are and what you would like to do to strengthen that connection. We can have them use mindfulness, reviewing their rich and meaningful life and deciding, how am I going to use my energy today to move toward something that's important to me? We can use cognitive restructuring to help them identify and modify inaccurate or unhelpful thoughts. Obviously, as the dementia progresses, cognitive restructuring becomes less effective. But in early stages of dementia, identifying thoughts like, this is hopeless, it's going to progress really fast, I am useless, those sorts of things, we can help them restructure. And by doing that, we're reducing stress, physiological stress, and inflammation. Help them with living in the and, embracing what is, and moving toward their rich and meaningful life despite challenges. You're working with Sally, and today's a good day for Sally, but she recognizes that the last 3 days have been bad. Okay, well, let's live in the and. How can you use your energy to embrace what is today, that you're having a good day, and move towards your rich and meaningful life, and acknowledge without criticism those bad days. All right, I had a bad day. Yeah, it is what it is. Getting angry about it is just going to increase stress and inflammation. We can help them with SMART goal setting, creating specific, measurable, achievable, realistic, and time-limited goals. When they're having good days, when they're present, what's one thing we can do right now to help you feel better? And you may substitute happy or empowered or whatever word you want to use. And by doing that, you're saying, okay, you do still have the ability to use your energy and move toward that rich and meaningful life, and, or despite, however you want to put it, also knowing that you have a diagnosis of dementia. We can work with self-talk modification, replacing negative self-talk with constructive, compassionate self-talk. Saying something maybe like, wow, it's really harsh to call yourself names because you forgot something. I know it's maddening, and it happens. We all do it sometimes. So let's talk about some strategies that you can use so you don't forget. For example, writing things down. Hardiness is commitment, control, and challenge, helping them recognize all of the things that are important in their rich and meaningful life, what aspects of their life they have control over right now, and viewing moving toward what's important in their life as a challenge. It's not overwhelming. And yes, there may be some obstacles in the way. So, all right, that's a challenge. Let's figure out how to move towards your life and deal with that challenge. Encourage them to keep a gratitude journal. Turn their attention to what is going right. We are hardwired to pay attention to what's going wrong. Forcing ourselves to turn our attention to what's going right. We're not ignoring what's going bad. We're saying, yeah, that exists. And all these other things over here are going pretty well. Tell me about your granddaughter. Tell me about your dog. Impact jars can be really fun. We used to do this in residential treatment. Have little slips of paper that residents can fill out that tell someone how their presence has positively impacted them. And then encourage the residents to read the notes and reflect on that experience. So if John says, it was really helpful to me and I felt really cared about when you checked on me today. Okay, so tell me about what was going on when you checked on John and how did you feel after you checked on him? Again, that can bring up the reminiscence therapy as well as increasing oxytocin and helping people really recognize that they do have an impact. Affective strategies, emotional awareness, help people identify and communicate their feelings. For patients with aphasia, it's important to make sure that you ask yes or no questions. You may have an emotion sheet that they can point to. You may empathize with their distress at not being able to be understood. Remember, aphasia is the difficulty in either using words. When they speak, it just comes out word salad, or understanding what's being said. It is important, however, for patients with aphasia to review their chart for a constraint-induced language therapy intervention, which means we really don't want to encourage people to use nodding or pointing. We want to encourage them to actually use their words. So you don't want your intervention to be counter to someone else's intervention, but there's also a meeting in the middle somewhere where if your patient is experiencing too much distress, that you make sure they do have a way to communicate with you, and then you can let the occupational or speech therapist know about what happened after the session. Distress tolerance skills help clients downregulate and manage their distress. Help write down 3 or 4 distress-tolerant thoughts and have them post it somewhere where they see it on a regular basis. Teach them grounding activities like looking around and identifying 5 things that are green. Teach them square breathing with or without bilateral stimulation. That means breathing in for 4, hold for 4, out for 4, hold for 4. That's square breathing. Now, bilateral stimulation would also involve either rubbing your arms like this or tapping like this while you're breathing. Some people find that intensifies the effectiveness of the square breathing. And encourage them to request assistance to reduce spiraling. If they feel like they're starting to get agitated, let them know, okay, when you start feeling that way, go talk to the charge nurse or go talk to whomever. And behavioral strategies. Biofeedback is one, and obviously you need a little bit of training in it, but basically you're going to put a polar heart rate monitor on the patient and you have it on the phone app so you can see their heart rate. And you're going to at first have them walk and then sit down. And when they sit down after they walk, you're going to watch their heart rate go down. You can use biofeedback in conjunction with exposure therapy as well as relaxation techniques. Behavioral activation therapy increases engagement in activities that provide a sense of accomplishment or pleasure. So we're doing things that help them feel purposeful. And role-playing can also stimulate communication as well as cognition. Practicing social skills or improving communication skills through simulated scenarios. In systemic counseling, we have family psychoeducation, in which we provide information about the illness, its course, causes, treatment, and prognosis to the family members. We need everybody in the system to kind of understand what's going on, what to look out for, and how we can best slow the progression. We can provide communication skills training to improve how family members interact and express themselves. We can help them recognize what current issues or problems mean to their loved one. If the older adult is starting to feel disempowered and useless because they can't do things they used to do, then they may have a lot more agitation. And it's not just because they can't do it, it's because it's a self-concept and a self-efficacy thing. Problem-solving techniques teach families how to approach and address life problems systemically and in an empowering way that includes the older adult. And structural interventions modify family dynamics and boundaries to improve functioning, identifying what the patient is actually able to do so loved ones aren't unintentionally kind of doing things for the patient and making them feel childlike. I'll go over billing notes after class. There are a lot of psychophysiological, emotional, cognitive, and systemic strategies that can be used to help patients live their highest quality of life. We want to recognize the cause for various behaviors and reactions in each piece of life. Physically, if they start eating too much, eating too little, sleeping too much, sleeping too little. Interpersonally, if they start withdrawing or becoming irritable. Emotionally, cognitively, environmentally, if they just let their surroundings kind of degenerate. We want to identify what's the underlying cause for these behaviors. If progress with the client is not being made, look for what was missed or change approaches. Not everybody's going to respond the same way to the same approaches. Be familiar with the rights of assisted living facility and nursing home residents. They have a Bill of Rights that is in the front lobby of the assisted living facility. You also want to familiarize yourself with the Ombudsman program. The Ombudsman is the patient advocate, and every state has them. Every assisted living facility has a poster in the lobby that has the number of the Ombudsman. If your patient or their family members think that they are not being treated correctly, if they think their rights are being violated, all they've got to do is make a call to the Ombudsman. It's a free service that is covered by your tax dollars, and that helps a lot of people feel more empowered and safer in that environment. All right, we went through a lot of things, barely got everything in there. I am going to continue to talk about billing and documentation if you want to continue watching. If you want to go take your quiz, more power to you. Have a great day. And next Monday, we will be talking about reducing agitation, the causes of agitation and ways to reduce agitation and sundowning. Okay, for those of you who are sticking around, let's go back up to this one. Just a note, if you are doing billing, you can bill group therapy or individual therapy once a day. Up to once a day if it's medically necessary. You can bill cognitive-focused therapy up to once a day if it's medically necessary. You can bill psychophysiological interventions like biofeedback up to once a day if it is considered medically necessary. And you can bill for family psychotherapy without the patient present up to once a week. So it is important to recognize what you can do. Now, you cannot bill for a patient on Medicare. You cannot bill for 3 hours of group therapy on the same day. You can bill once. You can bill, and you cannot bill for individual and group on the same day with the patient. There are some caveats you need to know. It's important to always check with your insurance provider and the Medicare Administrative Contractor, the MAC, for code compatibility and feed schedule. Not all Medicare and not all Medicaid programs cover the exact same things or allow the exact same services to be provided on the same day. Other little points of interest. Interprofessional telephone or internet consultations between healthcare professionals involving a verbal and written report, like your progress note. You send it over to the doc and you say, hey, we need to talk about this. That is actually a billable service under the CPT code 99445 through 99449, depending on how long it is. 99448 is the typical, because it generally is a 21-minute consultation by the time you call them and talk it out. It can possibly be used for communication with the family indirectly to support patient care with that same written and verbal report. So you may call and talk to the doctor or the charge nurse for 10 minutes, and then you may call and talk to the family for 11 minutes, and you've got your 21 minutes that you can bill for that interprofessional telephone internet consultation. Psychiatric collaborative care management for mental health providers collaborating with a medical personnel in managing a patient's care can be billed for 60 minutes at the beginning of care, and then every so often, I think it's quarterly, you can bill it again, where you actually have a team meeting to talk about where your patient is based on their disease progression. In terms of billing notes, if you're billing notes with family, you can provide individual therapy for 30 minutes, cognitive focused therapy for 15 minutes, a 15-minute psychophysiological intervention, so that's an hour with the patient, and family psychotherapy for 50 minutes without the patient present. It's another $88. Consultation with staff and family that exceeds 21 minutes. In that, you've got a total direct patient time that you're billing as a total of 2 hours and 25 minutes, and which averages out to roughly $107 an hour. Why am I bringing this up? Because it's important to be able to bill for your services, and it's important not to miss billing codes and do things basically for free that you could have gotten compensated for by Medicare or Medicaid. By the same token, it's vital to not provide services that are not medically necessary. If your patient doesn't need 30 minutes of individual therapy 3 days a week, then don't provide it. And overbilling can get you in just as much trouble as inaccurate billing. So hopefully this gives you some ideas about things that you can do if you're working in an assisted living facility, if you are working in a nursing home, or even providing in-home care and billing Medicare. I will mention I'm going to do an entire video on insurance come the beginning of the year. I've got a bunch of other stuff I need to do first, but we will talk about what Medicare Part A and Part B are, what Medicare Advantage is, and who qualifies for Medicaid, because a lot of older adults do not qualify for Medicaid. And we want to recognize and be aware of what we're billing and how it's directly impacting that patient. You know, we don't want to, most patients have to pay 20% of whatever you're billing as an outpatient provider. And if they're on Medicare Part A and B, there is no upper limit to that. So they're constantly paying 20% of your fee for every visit. And ethically, I think it's important to keep that in the forefront of our minds. Are there any questions? I know I'm supposed to be doing a live Q&A like right now, but I do want to answer questions. Thank you for answering those questions, Adriana. I really appreciate it. I appreciate everybody being here, and I will see you next Monday.